Do you know there are many types of vaginal abnormalities which are found in women? Hi everyone and welcome back to my channel SC Nursing Hub. Today you and I will be studying about different types of vaginal abnormalities found in women. In this video, we will be briefly discussing about all types of vaginal abnormalities found in women, their cause and how we can treat them. Before we get started, let me ask you one question. Do you know how many types of vaginal abnormalities are there in women? There are more than 5 types of vaginal abnormalities and we are going to look each one of them. Let's dive into our video. Our topic is vaginal abnormalities. There are 6 types of vaginal abnormalities and we will be going into each one of them. Before that, let's enlist each one of them. First one is narrow introitus. Next, vaginal agenesis. Third one is vaginal atresia. Fourth is vaginal septum. Fifth is hymen abnormalities. And the last one is other associated abnormalities. In this video, we will be dealing with all the vaginal abnormalities enlisted here. So let's get started. Before going into the video, do like and share and also subscribe to my channel for more such contents. And we are also available in Telegram channel with SC Nursing Hub, YouTube, Instagram and Facebook. So do check out for more information. SC Nursing Hub is available in Telegram channel. In that channel, we deal with different questions related to all the nursing subjects and there we play a question quiz. So you can also subscribe to SC Nursing Hub in Telegram channel and can upgrade your nursing skills. So let's get started with the today's vaginal abnormality topic. The first vaginal abnormalities we are going to see is narrow introitus. Before getting into it, let's recap the anatomy of female reproductive system. In this, we have the fundus, the fallopian tube, the uterus, the vaginal canal. This is the uterus. This is fallopian tube. This is fundus. This is vaginal canal. Now we are looking into the narrow introitus. Introitus, it is the opening of the vaginal canal. So this is introitus. Now, as the word suggests, narrow introitus means the narrowing of the introitus or the opening of the vaginal canal. So our definition will be, so it is the malformation of vagina causing narrowing of the introitus. Also we can understand like this is our external genital area. This is our anus, clitoris, labia majora, labia minora, urethral meatus and the vaginal opening or introitus. Now it is clear where it is situated, the outermost opening of the vagina, and it gets narrow due to any reason, the abnormality known as narrow introitus. This abnormalities majorly come to know to a woman when she is married. Before marriage or before coitus, she doesn't come to know that she is suffering from the narrow introitus. Now we will be seeing about the complaints. Complaints are, the commonest is dyspareunia. The most common complaints and the symptoms of narrow introitus is dyspareunia. What is dyspareunia? Dyspareunia is a persistent or recurrent pain of genital area occurs just before or during or after the intercourse. It is the commonest symptom of narrow introitus or vaginal abnormality. Now how we treat it? There is 2 types of treatment available for narrow introitus. The first one is manual and the second one is obvious surgical. Now what happens in manual? Under general anesthesia, manual stretching is done of the vagina opening or the introitus. And the next treatment of narrow introitus is surgical. The surgical enlargement of introitus is known as perineoplasty. Perineoplasty, and it is also known as Fenton's operation. So this is the narrow introitus, which is a vaginal abnormalities found in women, and it is basically found during the intercourse or when the examination is done for the infertility. That time only woman comes to know that she is suffering from narrow introitus. The second vaginal abnormalities we are going to see is vaginal agenesis. It is also known as hypoplasia. Before going into the topic, let's brush up our embryology. In embryology or the study of embryo, we have seen two ducts. We have studied about two ducts. That is, the first one is Mullerian duct and Wolffian duct. Now, what these two organs or these two parts or structure does to our embryo, the first, that is Mullerian duct, it is responsible for generating female reproductive system, okay, which comprises of oviduct, uterus, fallopian tube. Now Wolffian duct, what this structure does, it is responsible for generating male reproductive organs and kidney. Remember this, especially the Mullerian duct. It is responsible for making female reproductive structures. We are coming back to the vaginal agenesis. The incidence of vaginal agenesis is 1 in 5,000 to 7,000 women. The vaginal agenesis is a result of deformation of vagina or any reproductive organs in the female. It is the result of problem formed during the early development of reproductive system of fetus. Basically, what we have studied, that Mullerian duct is responsible for the female reproductive system, formation of female reproductive system. Hence, the etiology of the vaginal agenesis, which can be clearly understood, is the malformation of Mullerian duct, and this abnormality is also known as Rokitansky syndrome, which is associated with hypoplasia. What does hypoplasia means? It is degeneration or incomplete formation of any part that causes vaginal agenesis. In vaginal agenesis, it is as you come to know that it is the malformation of Mullerian duct. So there is absence of vagina, fallopian tube, cervix. So basically the inner reproductive organs are absent or malformed, okay, but the outer one are fully formed, and they don't show any of the malformations in them. And also the ovaries are fully formed and the chromosomes are well formed and well maintained. Now there are two types of vaginal agenesis. The one is complete and the another one is incomplete. Incomplete vaginal agenesis, in that some of the organs like vagina or fallopian tube or cervix, some of them have been generated and they are working well, but some are not. So it is incomplete vaginal agenesis, and it is also known as Rokitansky syndrome. But the other one, which is complete vaginal agenesis, in which incomplete vaginal agenesis, women have incomplete development of uterine remnant or horns. They are present, but they are malformed. Okay. Now next is complete vaginal agenesis. Vagina, fallopian tube, cervix, uterus, they all are absent, and hence it called as complete vaginal agenesis, and it is also known as Rokitansky-Meyer-Kuster-Husser syndrome, RMKH. The diagnosis. How we can diagnose that a female is suffering from vaginal agenesis or hypoplasia. Basically, or the female girl child come to 15 to 18 years of age and she complains of, or we have undergone the puberty changes, but we are not still menstruating. And after this age and the similar complaints, we run some tests like physical examination, hormonal and genetic testing, image study like USG, MRI, IVP, etc. to confirm the diagnosis of vaginal agenesis or hypoplasia. Now, what are the treatment of vaginal agenesis or hypoplasia? Again, there are two types of treatment available for vaginal agenesis. The first one is non-surgical and another one is obvious surgical. The non-surgical treatment comprises of pressure dilatation. In pressure dilatation, if there is 1 centimeter of dimple or depression is seen, then for 6 to 12 months, dilatation is being regularly done into the vagina, and this depression gradually increases and form vaginal opening, and it is the most effective one for a non-surgical treatment of vaginal agenesis. It was introduced by Frank in 1938. Now we will be talking about the surgical treatment of vaginal agenesis or hypoplasia. In surgical treatment of vaginal agenesis, there are many types of vaginoplasty is being done. There are 3 types of surgically vaginoplasty. First one is McIndoe-Reid procedure. Which was introduced in 1938. In this, what happened? A space is created digitally between the bladder and the rectum. Split thickness and skin graft is used over the mold. Next one is William vulvovaginoplasty. It was introduced in 1976. And nowadays it is not being practiced. Next, vaginoplasty with amniograft. It was introduced by Chakraborty Konar in 2004. Okay, so these are 3 surgical or vaginoplasty, types of 3 vaginoplasty, and in which Williams vulvovaginoplasty is not being practiced at present, but there was. this surgical method used during those days. Nowadays, we usually we do the pressure dilatation, which is the best of them all. But if it is needed that the dimples are not clearly visible, and so we go into the surgical treatment of vaginoagenesis, and in that we usually practice the Mac-Indo-Reed procedures, that is which was introduced in 1938, and the next one is vaginoplasty with amniograft, which was introduced in 2004. There are some complications also related to treatment, surgical treatment of vaginoplasty, that is VVF, RVF, bleeding. These are the complications of surgical treatment of vaginal agenesis. These three are during the surgery or just after the surgery, and later complications are dyspareunia restenosis. Then they are the later complication of surgical treatment of vaginoplasty. So this is all about vaginal agenesis. Vaginal agenesis, the incidence is 1 in 5,000 to 7,000 women. It is the result of problem formed during the early development of reproductive system of fetus, which is implied as malformation of Mullerian duct. It is also known as Rokitansky syndrome, and it is also known as hypoplasia. Hypoplasia means malformation of any of the organs. The diagnosis is generally diagnosed during the 15 to 18 years of age, when the woman come to a gynec OPD and states that I have come across the puberty age, I have gained all the pubertical changes like breast enlargement, hair growth, pubic hair growth, everything, but I don't have or I am not menstruating. Then we take her into the diagnosis. We run different tests like physical examination, careful physical examination, hormonal genetic testing, imagings like USG, IVP, MRI, etc. to diagnose what is the cause of non-menstruating woman. Then the vaginal agenesis, it is divided in, it is of two types, that is complete vaginal agenesis or hypoplasia, or incomplete vaginal agenesis hypoplasia. In incomplete vaginal agenesis, there is an incomplete uterine remnant or horns present in the body or in the female body, and incomplete or the complete vaginal agenesis have absent of vagina, fallopian tube, cervix and uterus. And the complete vaginal agenesis, it is known as Rokitansky-Meyer-Kuster-Husser syndrome, that is RMKH. The treatment of vaginal agenesis, whether it is incomplete or complete, the two types of treatment are present, that is one is non-surgical and the other one is surgical. In non-surgical, there is pressure dilatation, which is considered as best treatment for vaginal abnormality. In that, what happens, for 6 to 12 months, woman is being dilated with the vaginal dilators for the period of 6 to 12 months. If 1 centimeter of dimple or the dimple or you can say the depressed part is present in the vagina, then those depression is being dilated with the vaginal dilator for 6 to 12 months. And it was introduced by Frank in 1938. Next is surgical treatment of vaginal agenesis. It is the most common of surgical treatment of vaginal agenesis is vaginoplasty. There are different types of vaginoplasty. 3 we have studied. First one is Mac-Indo-Reed procedure. It was introduced in 1938. In this, a space is generated digitally between the bladder and the rectum. Split thickness skin graft is being used in this. The next one is William Volvo vaginoplasty, which was introduced in 1976. In this, a vagina pouch is being created in the area. And now this William Volvo vaginoplasty is not being practiced at all. Next is vaginoplasty with amniograft. In this, it was introduced by Chakraborty Konar in 2004. In this, formation of vagina is being placed. The complication of surgical treatment of vaginoplasty or vaginal reconstruction are RVF, bleeding, and the later complications we can see dyspareunia and restenosis.